We will now commence the academic program. We are now moving to the very first session for the day. I will now take opportunity to reintroduce you the chairpersons, Professor Dushanta Madhukethara and Dr. Amit Fernando. Over to you, sir.
Good morning. I welcome all of you to this symposia on asthma, bronchial asthma, on the day from the World Asthma Day programs, organized jointly by Sri Lanka College of Pulmonologists and the Indian Chest Society. And actually, I think you heard the very good welcome and introductory remarks about the current situation of bronchial asthma in the world, as well as in our subcontinent, and particularly in our country. Now, that actually quite enough for you to understand what's the purpose of having this type of symposia by listening to Dr. Rajada. And it is very, very important us to upgrade the knowledge of medical practitioners in every level, where our Deputy Director General also requested us, same thing, from the primary care onward to all the medical units and every other unit. And no one can stay in this country as being a doctor without knowing the proper knowledge of how to treat the bronchial asthma in each and every disciplines of the medicine in this country, not only in this country, all over the world. And we have several lectures lined up today, and going to give the update on the current knowledge according to evidence-based medicine. And hope every one of you, some are physically here, others are on connecting to our Zoom, and we'll get a better knowledge end of this session. And we'll have several lectures. In the first half of this session, we have 4 lectures, and we'll be addressed on the different aspects. And with my co-chair, Dr. Amit Fernando, and I'm kindly requesting all speakers to strictly adhere to the time. And we will have a question and answer session at the end. So then we can have smooth running of the program, and we'll have questions on the different topics, or even a general on the related to the topics, as well as asthma per se. And our senior consultants are around. Hopefully with them, we all can answer your questions. And I'm requesting all the speakers to remain after their lectures for a question and session. And I will invite my co-chair, Dr. Amit Fernando, to introduce the first speaker to you.
Good morning. Good morning. As we saw, asthma keeps evolving, and the new diagnostic, new challenges keeps there. So to give us the insights into this changing landscape of asthma diagnostics, it's my great pleasure to invite Dr. Ruwanthi Jayasekara, a consultant respiratory physician and senior lecturer, University of Morato, to give us insights into the diagnosis of asthma and the changing landscape.
Good morning. Thank you very much, dear sirs, and welcome to the first talk of the World Asthma Day. The inaugural slides of the President has set a very good platform for me to build upon to do justice to my topic, diagnosis of asthma, state of the art. So as you just heard a few minutes ago, bronchial asthma is a very common condition globally as well as in the local setting. However, when you say bronchial asthma, it may sound a simple term. However, it's a disease with a wide spectrum. It's a heterogeneous condition where at one point you will meet a patient who will have mild asthma going according to your guidelines, and you can treat with simple medications. However, your next patient will be a difficult to treat asthma, or an asthma patient who has a diagnosis of asthma where you find it very difficult to treat with your normal medication protocols. So when you have the term asthma in front of you, it may be asthma, it may be an asthma mimic, it may be a different, there are several phenotypes in asthma where we will have more input during the course of the day. There will be spectrums of disease like exercise-induced asthma, aspirin-induced asthma, fungal sensitization. So when you talk about the term bronchial asthma, it is just not one entity, but a huge spectrum that we have to do justice to. So when we talk about diagnostic, there is no one size fit all way of approaching, and therefore over the next 15 minutes or so, I will try to go through the various diagnostic methods that can be utilized to understand what goes on in our patient So in the end, our end aim or our main goal is to deliver individualized treatment. So bronchial asthma is a condition which may be underdiagnosed, which is misdiagnosed, may be undertreated or overtreated. So therefore, let's go through the armamentarium of diagnostics available for us to understand this disease deeply. So the outline of my talk, I will spend a few minutes on clinical evaluation, go through the various objective testing methods that are available for us, and touch on emerging technologies. So as you know, asthma is a common chronic respiratory condition characterized by airway inflammation, airway obstruction, and bronchial hyperresponsiveness. And effective diagnosis is crucial for appropriate management and optimal outcome. So when we are talking about diagnostics, we are trying to look at airway inflammation, try to demonstrate airway obstruction, and try to depict bronchial hyperresponsiveness. We always stand by the GINA guidelines when it comes to the management. That is our go-to when we look for evidence-based management in asthma. And GINA, the latest guideline says, test before treating wherever possible. Document the evidence for the diagnosis of asthma before starting controller treatment, as it is often more difficult to confirm the diagnosis afterwards. So when you have a clinical suspicion of an airway obstructive disease, to avoid unnecessary treatment, to avoid overtreatment, and to avoid missing other diagnoses, it's important to go ahead with diagnostics. So as always in any clinical condition, we start off with a clinical evaluation, taking a good history and followed by a physical examination. I know there are medical students around, so it's very important to take a good medical history, assess the symptoms of coughing, wheezing, shortness of chest tightness. You have to go into detail about the frequency, severity, diurnal variation, what are the triggers, family history, occupational exposures, smoking exposures. There's a huge burden of biomass fall exposure in our community without a gender discrepancy. Medication use. So a good history, as always, lays a good background. Then as for physical examination, we have to look for signs of airflow obstruction, wheezing, prolonged expiration, decreased breath sounds when we are auscultating. Then check for features of allergic rhinitis, nasal polyps, and signs of atopic dermatitis. So with this clinical evaluation, then we go ahead with our objective testing, which is my task today. So when we talk about diagnostics or objective testing, we start off with our basic lung function test, the spirometry, with bronchodilator reversibility. And for bronchodilator reversibility testing, we have various tests. And then you have adjuvant or ancillary testing, such as the impulse oscillometry, exercise challenge test, eucapnic hyperventilation, fractional exhalation of nitric oxide, cardiopulmonary exercise testing, as well as emerging modalities of diagnostics to help us come to a proper diagnosis of bronchial asthma. So we start with pulmonary function test, and spirometry is the cornerstone for asthma diagnosis, and we have to measure the forced expiratory volume in the first second and the forced vital capacity. As in the next slide, I will show that we look for a reduction in the FEV1, a reduction in the FVC, and a reduction in the FEV1 to FVC ratio. And once we identify obstruction or airflow obstruction in the spirometry, we have to look for reversibility to see whether it's a reversible airway disease, because bronchial asthma, as you know, is a reversible airway disease. So bronchodilator reversibility testing is the next step after a spirometry to assess the response to bronchodilators. So I will not spend too much time on spirometry because I have to go through all the other diagnostics. So what we do is we give a short-acting bronchodilator to the patient and look for an increase in the FEV1 of more than 12% and more than 200 ml which is considered a positive test. So apart from bronchodilator reversibility, you can also do methacholine challenge test or histamine challenge test to look for bronchial hyperresponsiveness. Now, if you look at these graphs, so these are on your left-hand side. That is a flow volume loop of a normal spirometry where the patient has achieved a nice peak expiratory flow and you have a beautiful expiratory and inspiratory flow volume. When we are asked to interpret a spirometry study, it is very important to look at the flow volume loop first before jumping on the values, because if the technique of performing the flow volume is inaccurate, if the patient does not have this nice flow volume loop for us to begin with, then there is no point in looking at the data. We can't interpret or come to a diagnosis. The patient should have taken a nice full inspiration and expiration, a complete circle, and there should be no cough in between. The patient should not have stopped the breath too soon. So always look whether the patient's flow volume loop is adequate for you to interpret or look at the data. It is also important when you are interpreting a flow volume loop or spirometry to look for obstructive airway disease. The patient's volume time curve, I will show in the next slide, the volume time curve should be at least 6 seconds expiration. So if the patient has stopped expiring or exhaling before 6 seconds, you just have to go and repeat the test. Right. So the middle flow volume loop shows airway. It's an airway obstruction. You can see the FEV1 has reduced, and in this patient, the FEV1 to FVC ratio is less than 0.75. And if you look at your right-hand side graph, there is a characteristic scooping out of the curve, which we see in emphysema. So this is so you have beautiful flow volume loops where you have normal spirometry, you have obstructive airway disease, emphysema, and the other flow volume loop patterns where you can get an idea about airway obstruction, tracheal stenosis, even vocal cord pathologies. So as it is on asthma, let's move on to talk about bronchial reversibility. So to demonstrate bronchodilator reversibility, the common test that is done in our clinics is to give a short-acting bronchodilator and look for a significant reversibility. And as I said before, an increase in FEV1 of more than 12% and more than 200 ml demonstrates bronchodilator reversibility, whereas in a child, in children, increasing of more than 12% is predicted, is enough. So this measurement is taken 10 to 15 minutes after 200 to 400 micrograms of salbutamol. So the pre-bronchodilator and post-bronchodilator readings are compared. Now, if you don't have bronchodilator reversibility testing in your unit, the other methods will be to look for variability using a peak expiratory flow meter. And according to the GINA guideline, we have to look for diurnal variation of peak flow variability of more than 10%. So the other tests that are there to look for bronchodilator reversibility are the methacholine challenge test, hyperventilation test, and the mannitol challenge test, where we again look for a reduction in the FEV1 or a drop in FEV1 of 20% from the baseline. Now let's look at so this is a spirometry study, and as I said, you have a flow volume loop. So before you look at all this whole lot of data in front of you, you look at the flow volume loop, and you see that there is a scoping of the expiratory curve. But it is nice that there is no stopping of breathing in between. The flow volume loop is nicely completed for you to interpret. And when you look at the exhalation, the patient has exhaled up to 6 seconds, so you are happy to look at the data now. So here you look at the FEV1. The FEV1 in the first second, forced expiratory volume in the first second is 42%. The FVC in the first second, the forced vital capacity is 59%, and the ratio is 60%. So it is obstruction. So you have demonstrated airway obstruction, and now you have to look for reversibility. So you look at the FEV1 pre-bronchodilator and post bronchodilator. So you see that it has increased significantly from 42% to 65% with a change of 54%. So and it's a significant reduction. And when there is a very high bronchodilator reversibility, it is a predictor of frequent exacerbations. So now, to perform this lung function test, the patient has to comply well, the patient has to listen to the instructions given by the physiotherapist and has to take a deep breath and blow out fast. So to follow the instructions to perform a good flow volume loop, the patient has to have a certain level of intelligence. So small children, elderly people who can't follow who may not be able to follow what you are saying, or people who find it anyway difficult to do a spirometry, we can do the test called impulse oscillometry, because impulse oscillometry, it is available in several units in the country. It is an effort independent measurement of both airway resistance and airway reactance based on an oscillation technique. So here, the patient does not have to take large breaths and blow out, and there are no difficult commands to follow. It is a simple tidal volume breath that the patient will be asked to take, and we will be able to give we will be able to have an understanding whether the patient has obstructive airway disease. Impulse oscillometry is more sensitive for peripheral airway obstruction. As you can see in this picture, for children less than 7 years who find it difficult to follow your command, we do the impulse oscillometry. If you have a normal spirometry and you still feel that there's some element of obstructive airway disease going on, or whether you're not sure whether it is a small airway disease or a large airway disease or a central airway disease, then impulse oscillometry is very helpful, and you can always check for the bronchodilator response as well. Here it is an excerpt from the report of the impulse oscillometry. So I know all of you are not familiar with it, but if I go through the very few simple terms, here we look at the values called reactance and resistance. So airway resistance at 5 Hz will be where an impulse is sent at 5 Hz, and that will demonstrate airway obstruction of the whole airway. Or if there is an obstruction in the airway, the reactance at 5 Hz will be very high. It will be more than 140%. In this patient, it is 185%. Then reactance at 20 Hz will be where it will demonstrate obstructive airway disease at the central airways. So that is also 115%. It is high. And if you want to look whether there is distal airway, or small airway disease, you look at what you call the R5 minus R20. R5 is whole airway minus the whole airway resistance minus the large airway resistance. You get the small airway resistance. So when it is more than 80%, again there is airway obstruction. So even if you have a normal spirometry or spirometry that is difficult to interpret, you can do the impulse oscillometry and get an idea where there is airway resistance, and airway reactance is another entity where we look for where the reactance reduces or more the negative value. So I'm not going to, what I wanted to do is to give you an introduction that these tests are available if you have in difficult to diagnose cases. And in conditions where such as excessive dynamic airway collapse, EDAC, where there is the upper airway, the central airway obstruction, you can use the impulse oscillometry to get an idea whether there is central airway obstruction. Next, we move on to the FeNO. Fractional exhaled nitric oxide is another diagnostic test that is available to reflect airway inflammation and can aid in the asthma diagnosis and monitoring. Elevated FeNO more than 25 parts per billion suggests eosinophilic inflammation. So it is an adjuvant in the diagnosis. It helps in the diagnosis, and it also helps in the management to identify patients who will respond to inhaled corticosteroid, for us to decide whether we need to step up on the inhaled corticosteroid or whether the patient is complying with our treatment. So here I have put an excerpt from a FeNO report. This is performed and interpreted by Dr. Dilesha Vadasinghe, consultant respiratory physician. I thank her for this document. This FeNO, the FeNO testing, it's a simple test where the patient has to blow through that simple equipment I showed you, and we can get an idea about the eosinophilic inflammation in in the patient. So in this test, you can see the readings are 43, 41, 43 parts per billion. So when the normal is less than 25 parts per billion, and if it is more than 50, you are sure there is eosinophilic airway inflammation. So it is coming close to that. However, it is not only for asthma, but there are other conditions like eosinophilic bronchitis, atopy, allergic rhinitis, which will also increase the FeNO level, and also it will be lower in smokers. So we have to remember that when we are interpreting. So FeNO is currently a new, well, it's fairly new here, but it's been there for some time, which is currently been utilized to aid the diagnostic. As I said, it's an adjuvant in diagnosis and also helps us to optimize management in our patients. Then let's look at asthma in the athlete. When you have this cohort of players who are going for Olympics, for the Asian Games, there is a huge population of asthma and also asthma mimics, because athletes, they have to do sports in they have to do endurance training. They have to exercise in dry air, and that can precipitate airway problems, and it can mimic inducible laryngeal obstruction. They can come with conditions which mimic asthma, such as inducible laryngeal obstruction, dysfunctional breathing, cardiac conditions, training. So for when as medical professionals or respiratory physicians, we are faced with athletes who come with asthma, we have to give them a proper diagnosis. And to aid that, we have what we call the exercise challenge test. So exercise-induced bronchoconstriction describes acute airway narrowing that occurs because of exercise. And we do, even the athletes, so the International Olympic Committee has given a list of diagnostics that we can do to come to a diagnosis. So apart from our normal spirometry and bronchodilator reversibility, they have mentioned the exercise challenge test, where we get the patient to exercise on a treadmill or a cycle ergometer, and we do serial FEV1s, the forced expiratory volume in 1 second, after 15 minutes of exercise up to their maximum heart rate. So we get them to exercise to 80% of their maximum heart rate, and then we do post-test FEV1, 5, 10, 15, 20-minute exercise. And then we look at the change in the FEV1 after exercise. So here you have, this is one of the exercise challenge test reports. We have a baseline FEV1, and you get the patient to exercise for 15 minutes of maximum heart rate, 15 minutes of 80% of their maximum heart rate on a treadmill or a cycle. And then we measure the FEV1 post-exercise 5, 10, 15 minutes, and you look for a drop in 10% at any of the values which will diagnose exercise-induced asthma. Then apart from the exercise, you don't have a cycle ergometer or a treadmill, then another simple test is the eukapnic voluntary hyperventilation that again helps us to diagnose exercise-induced asthma, where the patient breathes a specific gas mixture, and they have to maintain a high minute ventilation for 6 minutes, and spirometry is done again just like the exercise challenge test to look for a drop. And in athletes, they also have this inducible laryngeal obstruction, which can mimic asthma, and cardiopulmonary exercise testing is another ancillary test that can be utilized to see whether the problem is with the ventilation, metabolism, or cardiac. Sputum eosinophil count is also mentioned as one of the adjuvant tests. However, it is not used frequently because of the limited access to it. So sputum eosinophilia more than 3% again is helpful, but it's not used in our setting. You have this entity called asthma with fungal sensitization, where you don't be, so it's where you have asthma and you have the ABPA in 2 spectrums, and you have this condition where you have acute asthma with fungal sensitization, where the skin prick testing is positive. And the specific IG is positive, but it does not show any CT features of bronchopulmonary aspergillosis, and this can precipitate acute exacerbations of asthma. So diagnose or doing diagnostics to identify this condition is also you have to keep in mind. 2 more slides. Aspirin exacerbated respiratory disease. So aspirin sensitization or aspirin challenge test is another diagnostic test that is being done. It has been done in the cardiology unit at here in NHSL as well, where patients have aspirin sensitivity, the triad of nasal polyp sensitivity to aspirin and asthma, these people undergo an aspirin challenge test where there's progressive administration of increasing doses of aspirin. It is done in the ICU with close monitoring to diagnose and also to help desensitize this condition. Finally, we have several emerging technologies, exhale breath biomarkers and biomarker panels, and of course the HRCT to help us with further diagnosis. So these exhale breath biomarkers are up and coming modalities of diagnostics. There's there's a lot of material that we are exhaling in our exhale breath, so that those compounds are being utilized to come into diagnostics. Volatile organic compounds or VOCs in the exhale breath are being used. So one is what we saw, the FeNO, the fractional exhaled nitric oxide. Apart from that, there's an entity called breath prints or breathomics, where people are now trying to map out what we are exhaling, so it will help in the diagnosis of not only asthma but even lung cancer. And there is the electronic nose or the e-nose that is also coming up, where they are profiling exhale compounds to come to help in the or come to a diagnosis and also to help monitoring treatment. And when it comes to biomarker panels, I think there will be more talk about the IgE levels, but I want to give a word about periostin, which is again a molecular marker which is upcoming. It is still at research level and used in research in other countries, still not in the clinical setting. However, it is the next level of investigation which gives an idea about the genoendotype of asthma or type 2 airway inflammation, where the blood periostin level will be high with type 2 inflammation. And when we identify patients with different, so you will hear about different phenotypes as we go along the day. So these diagnostics can be utilized in different phenotypes to help us to come to a diagnosis. And our ultimate aim is to actually understand what is going on in the patients, because bronchial asthma is not just one entity, it's a whole spectrum, and we have to evaluate the patients properly to provide a good individualistic treatment for optimized care. Right. So if there are any questions, I'll be happy to take at the end. Thank you very much.
Thanks, Ranti. Now we'll get into the next lecture. GINA 2020, an update on managing asthma, to be delivered by Dr. Damitra Drigo, the consultant respiratory physician, District General Hospital, Hambantota. Damitra, over to you.
Good morning to you, and thank you very much, dear Chairperson, sir, for that introduction. So my task in this forum is to GINA 2023 update on managing asthma. We'll move on. So GINA stands for Global Initiative for Asthma. It was established in 1993 by the World Health Organization and the National Heart, Lung and Blood Institute. So last year in 2023, they celebrated their 30th anniversary. The main aim for establishing the organization was to increase the awareness of asthma, as well as to improve the prevention and management of asthma in a worldwide coordinated manner. This became an independent body in 2014. So what is important about GINA is now GINA issues a guideline for the clinicians every year. So the guideline is updated annually. So if you consider any other guideline issued by other countries or other institutions, they are not frequently updated. Some guidelines, in fact, if you take the American guideline, it hasn't been updated for a decade. So GINA makes sure that with the best available evidence for the year, there's an expert panel which looks into this evidence, and they do twice yearly cumulative review, and they update the guideline. And the newest update is usually issued along with the World Asthma Day. So we are celebrating the World Asthma Day tomorrow. The World Asthma Day is usually falls on the first Tuesday of the month of May. So for this year, it falls on 7th of May, which is tomorrow. So this is the theme for this year. Asthma education empowers, information is key. So as Dr. Rajada, the Secretary of the Indian Chest Society, said in his speech, this is exactly what we are doing. We are educating our doctors, our staff on asthma. So asthma education empowers. Information is the key. So you might be wondering why I am talking about the 2023 guideline here, because we are in 2024. Yes, because this 2024 guideline is still not issued. I checked in the internet in the morning as well. We are hoping the 2024 update to be issued, to be put out in the internet probably within tomorrow, or maybe within the next few hours even. So for the time being, we'll focus on the 2023 update to see what is new in the management of asthma. Right, so these are the key aspects that I want you to focus on, because towards the after 2021, or in 2022 rather, GINA made some landmark changes in the management pathway of asthma. So these are the I have picked up 12 areas for the discussion. If the time permits, we'll go through them. So because of the time constraint, we'll go through them one by one. So GINA has been giving now more emphasis on this personalized asthma management, because one size doesn't fit all. So your asthma is different from someone else's asthma. So so they give more emphasis on this cyclical management of assessment, adjustment, and review in asthma. So we'll see what it is. So first you should assess the patient and confirm the diagnosis first. This is what Ruandi was talking about. You should, if the diagnosis is not documented, you should always get the patient's history to look for the symptoms of asthma, and confirm the diagnosis by showing a variable expiratory airflow limitation by a pre and a post bronchodilator pulmonary function test, what Ruandi was talking about. And then the symptom assessment, as well as the assessment for risk factors and comorbidities. And then you have to think of the inhaler, and you have to take the patient considerations, patient's preferences and goals also in the assessment. Then you, in the adjustment, you adjust the patient's drugs, and then the pharmacological assessment and non-pharmacological assessment is there, and also adjustment of risk factors and comorbidities, and education of the patient is also important. Once you adjust your medication, then you should review your patient, and these are the things that you should review your patient's symptoms, the risk of exacerbations, whether the patient has gone into exacerbations, the drug side effects, the lung functions also they have included in the review, and review for comorbidities, and also for patient satisfaction. So what is important here is it should be a personalized way that you should do it, because one size doesn't fit all. So in 2022, GINA introduced this new terminology in this stepwise management of asthma. So this new concept of anti-inflammatory reliever therapy came in 2022, and in 2023 this has been more emphasized. So for years, our reliever has been SABA, or short-acting beta agonist, or salbutamol inhalers. But then there were more evidence coming for these anti-inflammatory relievers. So what it is you should have a anti-inflammatory drug as the reliever, where you have to use an inhaled corticosteroid along with the rapid-acting bronchodilator. So this is what you mean by anti-inflammatory reliever. So for the rapid-acting bronchodilator, you predominantly have two options according to GINA, either to use formoterol. Mind you, formoterol is a long-acting beta agonist, or a LABA, but still it has a relatively rapid onset of action. Therefore, you can use formoterol as a rapid-acting bronchodilator there. The second option is to use the conventional SABA, or short-acting bronchodilator. So you have two options again, to combine inhaled corticosteroid with formoterol, where you have the ICS formoterol combination as the anti-inflammatory reliever, or else you can combine the inhaled corticosteroid with SABA, then you have the ICS-SABA combination. So these are the two options for the anti-inflammatory reliever. The second main important terminology is the maintenance therapy. Maintenance therapy is asthma treatment that is prescribed every day for the patient to be taken on a fixed regular basis, even though the patient doesn't have symptoms. So for the years, maintenance therapy has mainly been ICS or inhaled corticosteroid containing treatment, either ICS monotherapy or ICS LABA dual combination or ICS LABA and LAMA triple combination. And your leukotriene receptor antagonists or montelukast and biologics also comes under maintenance therapy now. So the term controller therapy is less used, but it is used in synonymous with the maintenance therapy now. This is the medications that are targeting the both domains of asthma control, the symptom control and future risk. Reliever therapy is what we talked about. It's these are the reliever that we give on an as and when needed basis to relieve the symptoms, the conventional SABA, as well as the new as needed ICS formoterol as the reliever or the anti-inflammatory reliever or AR, or as needed ICS SABA also has a place we'll discuss. And the most important term is MART or maintenance and reliever therapy. So this is where the ICS formoterol combination comes into play, where ICS formoterol is used as daily maintenance as well as a reliever. So this is what we call maintenance and reliever therapy or maintenance and reliever treatment with ICS formoterol. So we'll move, so GINA in 2022 gave us 2 tracks of treatment in the stepwise management for the first time, and 2023 they have more emphasized this as track 1 being preferred. So we'll see what this is. So in the track 1, there's a preferred control and a reliever. And for this, the drug that they have introduced is ICS formoterol combination. Mind you, SABA is no longer regarded as a reliever alone, or pure SABA is not considered as a reliever because there's high risk of exacerbations. So for the step 1, where your patient has mild, less symptoms, maybe less than 4 or 5 days a week, you can give a as and when needed or as needed low dose ICS formoterol in the first 1 and 2 steps. If your patient has slightly more symptoms, you have to step up to step 3, where you give a continuous low dose maintenance ICS formoterol as step 3. And if your patient is not controlled, then you move on to step 4, where you give a medium dose maintenance continuous ICS formoterol, or else you have to, if the patient is still not controlled, you have to move on to step 5, of course. Then you are left with few options, rather adding a LAMA or long-acting muscarinic antagonist to ICS formoterol combination, and refer your patient for the phenotypic assessment to start a biologic even. So remember, throughout these stages, your reliever is as needed. ICS formoterol. So we'll move on to the second tract or the alternative tract. GINA gives the second option. If the track 1 is not practical, or the track 1 cannot be practiced because you don't have ICS formoterol, probably like in our setting, because we don't have ICS formoterol in our clinics. So this is the track 2, where you have, this is an alternative control and a reliever, and here the reliever is as needed ICS SABA or as needed SABA. Again, I must emphasize here that if you use SABA alone, you can't use SABA alone here, or even in step 1, according to the newest GINA guideline, if you are using SABA as a reliever on as and when needed basis, even in step 1, you have to combine it with the inhaled corticosteroid. So in the step 2, if a patient has more symptoms, you can start a low dose maintenance inhaled corticosteroid in this pathway. In step 3, you can introduce a low dose maintenance ICS LABA combination, And in step 4, if the patient is not controlled on step 3, you have to increase your dose as a medium to high dose maintenance ICS LABA. And still, if the patient is not controlled, like in in the track 1, your options are either adding a LAMA for this combination, or refer for a phenotypic assessment and to consider a biologic. So remember, here the reliever is as needed ICS SABA or as needed SABA. If you can't use SABA alone, even in step 1, if you are using SABA as and when needed basis, always you have to take a second inhaler which contains an inhaled corticosteroid. Or else if you have ICS SABA combinations, you can use it there, but unfortunately we don't have them. Right. So just emphasizing the same here. In track 1, the reliever is ICS formoterol only. And in the track 1, which is the preferred pathway, in the first 2 steps, what we practice is what we call the AR concept, or anti-inflammatory reliever, because we are giving anti-inflammatory reliever or ICS formoterol low dose on an as and when needed basis. From step 3 to 5, what we practice is what we call the MART, or maintenance and reliever therapy, where we use the same ICS formoterol single inhaler as a maintenance on a continuous daily basis, as well as the same inhaler you use as a reliever. This is what we call the maintenance and reliever therapy. And if you use a single inhaler, you call this SMART, or single inhaler maintenance and reliever therapy. Right. So yeah, this is what I told you. If you are using SABA as a reliever, you always have to combine it with inhaled corticosteroid. So GINA now has been moving out from these other control options, it seems. From 2022, they showed this, but in 2023, they have more emphasized this. You can see these other control options have been printed in very small font letters. It has moved down in the in this diagram, where your leukotriene receptor antagonists and theophylline, the other control options, have been given very less weight. So that is something new. So why this ICS formoterol combination? So as I've told you, GINA always looks for evidence. That's how they update their guidelines. So there have been more and more evidence coming for this ICS formoterol combination when we compare with SABA. So there had been significant risk of severe exacerbation when we are using ICS formoterol as a reliever compared to SABA. There had been 55% reduction of severe risk of exacerbations, and also the risk of emergency department visits and hospitalizations. Also, there had been a 65% reduction. Therefore, there's significantly significantly more evidence for as needed ICS formoterol combination. In the step 3 to 5, where we give MART, or maintenance and reliever therapy with ICS formoterol, again, there had been significant evidence. This slide, I think, Niranjan showed in his introduction speech as well, where we have now gross evidence, robust evidence for MART therapy with ICS formoterol. Remember, in track 2, where we don't have ICS formoterol, the alternative pathway was to use a ICS SABA as a reliever. There is evidence, but that evidence is not as robust as ICS formoterol, not as strong as ICS formoterol. In fact, there was only one clinical trial where albuterol and budesonide was used as ICS SABA reliever, and still it was shown superior to SABA alone. So this was the evidence for track 2 reliever. Right. So in summary, track 1 has low dose ICS formoterol as the reliever therapy throughout on as when needed basis, and there have been multiple randomized control trials have revealed superiority of ICS formoterol as the reliever, superior to SABA in reducing severe exacerbations. And this approach is now this approach is more simplified, in fact, because we use a single inhaler for both maintenance and reliever. This is what we call single inhaler maintenance and reliever therapy, or SMART therapy, and therefore it's easy for the clinician and easy for the patients as well. This is what GINA says. And the evidence supporting ICS SABA in the track 2, there is remember, there is still there's evidence, but only one randomized control trial is there. And that's why it's in the track 2, I think. So GINA goes on to give some guidance on the medicines as well as the doses that we should use in track 1, because there had been some confusion of how much of ICS formoterol can be given to a patient. So this time they have given a beautiful diagram showing the doses and the drugs that we can use in the ICS formoterol combination. Mind you, there's evidence for only 2 combinations, either budesonide formoterol or beclomethasone formoterol. So in step 1, where you practice air only, that is as when needed ICS formoterol, you are giving just ICS formoterol low dose. The preferred inhaler, mind you, is 206. This is what GINA recommends, because we know we have 412 preparations as well, but 206 is the inhaler. Because we are going with a single inhaler, you can go with 206. So for the step 1, you can give 1 inhalation as when needed basis. In step 3, where you should give a continuous low dose ICS formoterol, you can give 1 puff either once a day or twice a day. And again, the reliever is the same inhaler taken 1 inhalation on a as needed basis. For step 4, where we practice SMART, again, you can increase the number of inhalations to 2 inhalations twice a day. Again, the reliever is 1 as needed, same puff. So remember, you don't increase your, you don't change your the inhaler here. It is the same 206 inhaler. You are increasing the number of puffs even when you are increasing the control. You don't change your inhaler. Say you are starting with a 206 inhaler, 1 puff twice a day, and then if you are going to increase the controller, you are increasing the number of puffs. And step 5, again 2 inhalers twice a day. This is the number of puffs, that maximum number of puffs you can give. If you are using the ICS formoterol combination, you can go up to 12 inhalations a day. That is when you take as needed and maintenance both. If you are using the beclomethasone formoterol combination, the maximum number of inhalations you can give is 8. GINA gives some practical guide for the using of track 1 as well, because most of your patients had been used to your SABA reliever. So they emphasize that you educate your patients to use ICS formoterol combination as the reliever, because it has more evidence now. So they have mentioned that. And in fact, patient can even use two inhalers, 1 at home and 1 in the bag or pocket when they are traveling. And they are talking about this personalized asthma management plan as well, to give a plan to your patient what they should be using. If you are giving this SMART therapy to your patient, the normal mode, where how much of a control or maintenance treatment you should give, and when to increase the number of puffs in a flare up, and what you should be doing in an emergency. GINA has been showing some interest in the environmental consideration as well in choosing inhalers, because now the inhalers that we use, in fact, they are all CFC free, or we have HFA, but they are more concerned about the environmental pollution, and they asked us to use these recyclable inhalers, the plastic recyclable inhalers. And also using the SMART therapy, also you are using 1 inhaler, so that will also reduce the number of inhaler waste. For advice to low and medium income countries, because we have lack of access to track 1, because we don't have ICS formoterol combinations freely, use track 2, but in case if you have poor accessibility to track 1, but track 1 is always preferred. The update on vaccination has not changed. Yearly influenza vaccination is recommended, and pneumococcal, that is for moderate to severe asthma, mind you. Pneumococcal low pertussis vaccine is not recommended. Severe asthma management updates I won't be focusing on, because we will have 2 eminent speakers talking about this. Just what I want to focus is biologics are recommended only in severe asthma, but you have to have optimized treatment for that. The management in the exacerbations. So if your reliever, mind you, is ICS formoterol, I have told this before, in an exacerbation, you can ask your patient to increase the number of doses of the low dose ICS formoterol, the frequency of taking that inhaler. You can go up to 12 inhalations a day if you are using the 206 inhaler. And patients who are on MART therapy, they can continue their maintenance maintenance dose of ICS formoterol, and what they have to do is they can increase the reliever ICS formoterol as needed. And in more severe exacerbations, oral steroids still has the place, but if you are giving oral steroids, morning doses are preferred. There's been some updates in the non-pharmacological management. I have quickly run through because I have run out of time. There's gross evidence or level A evidence for cessation of smoking, as well as active and passive smoking both. And for physical activity also, you should encourage your patients to engage in more physical activity. You should not ask them not to exercise. So this has level A evidence. And of course, the avoidance of allergens. There's no general strategy for avoiding allergens. You can't say everyone to, now our patients are asking whether to eat this, eat that, but you can't generally ask them to avoid everything. It has to be, you have to test your patients for these allergies, and if you know them, you can avoid. They have great level A evidence. And there's level A evidence for remediation of dampness in molds, and most of our homes have these damp walls and things. That has a very good evidence, level A evidence. And when you consider outdoor air pollution, there's limited evidence. Evidence is almost low. So that is what I have to talk about. Sorry, I have run a bit out of time, and I'm happy to answer any question at the Q&A session. Thank you.
Thank you, Damit, for those insights of the most recent GINA updates that you have given. It's my pleasure to invite Dr. Vipula Bhattaduarachi to talk about occupational asthma. 28% of adult onset asthma is occupation related, late adult onset asthma, and we are interested to listen to Vipula on his insights.
Good morning. Thank you, sir, for that kind introduction. So my presentation will be mainly focused on giving you an outline of occupational asthma, the current state of the occupational asthma. So I'll be focusing on what is occupational asthma, the classification, epidemiology, how to diagnose, current management, prevention, challenges, and future needs. So what is occupational asthma? It's kind of a forgotten domain of asthma. Occupational asthma is de novo asthma induced by either sensitization to specific substance or a chemical at work. So it's basically de novo asthma, not pre-existing asthma. So moving on to the classification, this is quite important when we diagnose and manage occupational asthma. So it broadly included in the category of work-related asthma. So work-related asthma has two main domains, phenotypes. Work-exacerbated asthma, which is pre-existing asthma exacerbated during the work due to antigenic exposure. Then occupational asthma, which is de novo asthma, which has a direct link with antigens exposed during the occupation. Then occupational asthma has two other phenotypes at least, sensitizer-induced occupational asthma and irritant-induced occupational asthma. Sensitizer-induced occupational asthma has more immune basis, and there are two categories based on the size of the antigen. The size of the molecule, the high molecular weight, mainly proteins which act as potent antigens. Then low molecular weight substances like polysaccharides, which can act as haptens. The pattern of the presentation is based on the underlying whatever the antigen. The sensitizer-induced occupational asthma, there is a latency period of exposure which takes time taken to develop the immune reaction or sensitization before the symptoms begins. So there's a temporal relationship. Then irritant-induced occupational asthma has two forms, acute onset form and delayed onset form. The acute onset form, we call it reactive airway dysfunction syndrome, which is quite acute, where the symptom starts 24 hours after a single high-level antigenic exposure or inhaled irritant. Then delayed onset form, which develops quite insidiously over a time after acute exposure. So it's or after repeated low level exposure, we call it low dose RADS. Just to show you the categorization again, what I wanted to highlight is if you pick an antigen, it's important to categorize and see what category the antigen or the trigger is falling into. I don't want to go through each and every trigger. So it's the same thing what I have described so far, the classification. Then moving on to the epidemiology, up to 25% of adult asthma is work-related. The most common form is occupational asthma is sensitizer-induced occupational asthma, which represent about majority, more than 90% of the cases. Then the rest is irritant-induced occupational asthma. Actually, the only sporadic cases may be reported. There is no uniform way of kind of reporting. It's always underreported, underdiagnosed. An isolated case may be the first sign of much more extensive problem. But we do not usually go into kind of detailed assessment or distribution to identify the kind of pattern of presentation. In our setting, we don't have data on this special aspect, occupational asthma. This is a study we conducted last year, a small study which is actually a part of another study. We collected data from textile workers in free trade zone, and we found that quite a number of allergic symptoms in that specific occupational category, which are quite allergic related symptoms, respiratory symptoms, but we can't attribute this to occupational asthma straight away. This is not still present, the published also. There can be overlapping with other respiratory illnesses as well, but it gives a kind of a clue about the problem. Little bit of pathophysiology. Now we have a lot of interest on this antigen epithelial interaction, which is the starting point, and it leads to a lot of alternative pathways, immune pathways, causing activation of potent downstream immune response. So I don't want to complicate you, but like innate lymphocytic cells, then interleukin 25, 33. So those are kind of new immune component of interest. Many meta-analyses have found that there is a direct link between the level of exposure, cigarette smoking, and atopy, with which make patients prone to occupational asthma. So these are kind of risk factors which might make the patient vulnerable for occupational asthma with the exposure to the trigger. So this is how they presented the phenotype: immediate asthmatic reaction and late asthmatic reaction. However, there is a lot of variation between patients. There is no fixed kind of presentation, even the timing and the temporal relationship. Immediate asthmatic reaction usually occurs within few minutes of inhalation challenge and reaches maximum within about 30 minutes and ends within 60 to 90 minutes. So that's the immediate reaction. This related to the underlying immune pathology actually. Then the late asthmatic reaction occurs 4 to 6 hours after the inhalation challenge and reaches maximum within 8 to 10 hours and ends after 24 to 48 hours. Then how to diagnose occupational asthma? It requires two steps: confirmation of the diagnosis of asthma and to show the kind of link between workplace condition, workplace exposure. So the classic presentation, which does not happen each time, is that symptoms are worse at work and better on weekends or vacations away from work. Variable latency period ranging from weeks to years after the first exposure. So that is the challenge. Latency period can vary significantly. The work-related allergic rhinitis, conjunctivitis can be associated. Over a period of weeks or months, symptom usually becomes more severe and severe. So that is, with the continuous antigenic exposure, the immune reaction become strong and strong, and the patient's symptoms become more severe and severe. Then the history should include a very comprehensive the collection of data related to the occupation, description of the exact task and the process, work environment, respiratory protective precautions, identification of direct and indirect exposure to potent workplace asthmagens. So this has to be done very comprehensively. Then respiratory symptoms, the nature, latency period, and the temporal relationship with the work exposure. So that will improve the sensitivity of the history. Then associated work-related rhinitis, conjunctivitis, urticaria, or contact dermatitis. Then there are questionnaires to assess occupational asthma. However, none of these are very sensitive or specific tools. So we have to go by holistic approach with complemented with relevant investigations. The important differential diagnoses are vocal cord dysfunction, hyperventilation syndromes, and mass psychogenic illness, especially which can occur in a setting where a lot of workers are there working. Then this is just an outline of the diagnostic workup, starting from history and diagnostic tests. So there are two main arms, non-specific test and specific test. Non-specific test basically to confirm asthma. Then the specific test will help to identify the specific antigen. This should be actually, specific test should be very targeted testing if needed. Most important part are to confirm the history then and to confirm the asthma. There are practical problems associated with this specific test also, but before that, the peak flow monitoring has an important role in diagnosing occupational asthma, which is a simple test but has to be used. The protocol has to be very thorough and should adhere 100%. Otherwise, it's useless. The serial peak flow meter measurement should be obtained at least 4 times a day, not twice, 4 times a day, no more than 2-3 hours apart during the course of 2 weeks at work and 2 weeks away from work. So that has to be very specific. However, there can be practical problems to for example, take measurements away from work. In UK also I have seen they are just measuring during work only, but if you do it properly, it will improve the sensitivity and the specificity. Then for comparative analysis, the best triplicate recordings made at each time point is used. The serial peak flow measurements are highly sensitive and specific if done properly, but there is variable evidence also. Then we have this overseas 2 freeware, which was developed by a UK team, which is also helpful, which is available online to assess peak flow readings. This is the software, which is very helpful tool. Then this is just to show you an example of peak flow chart. Documentation also very important, so we have to educate the patient how to document. If you look at that shaded area, that is the work period, you can see mean peak flow, expiratory flow falls during work, and there is daily variation has increased. So that is quite supportive of the diagnosis of occupational asthma link. Then specific immune challenge testing is gold standard, but still it's not very practical test because of the risk associated, immune related the anaphylaxis and risk. So it has to be done in very specific situations. Even in UK, what I have seen is they do it in very selected patients only. Then it will actually mimic workplace exposure in a controlled environment. And the contraindications, very important to exclude: the uncontrolled asthma, FEV1 60%, recent to unstable cardiovascular disease, uncontrolled epilepsy, pregnancy, recent respiratory tract infections, and patients' inability to understand the procedure. I just included that just to show you that certain things we should, in certain situations, that we should avoid it. Then control asthma medication should be stopped. And how we diagnose: a drop in FEV1 or at least 50% from the baseline for a minimum of 6 hours after exposure to the suspected agent is considered a positive response. These are always supportive diagnostic tools. So the current management, the early diagnosis is essential for a favorable outcome. The aim is aimed at achieving a good control of symptoms and minimizing the future risk, the future development of similar or continuation of the problem. Aggressive pharmacotherapy is never considered sufficient in this special category, occupational asthma. Ideally, patients with sensitizing-induced occupational asthma should be completely relocated to a different occupation. But this is not practically possible. In that case, decreased exposure remain a reasonable option. Just to show the management, there are 3 steps: primary prevention, secondary prevention, that is early detection, and tertiary, that is appropriate treatment. So these are quite almost similar kind of interventions. Avoidance of induction of new possible sensitizing agents. For that, we should have an idea about what agents causing occupational asthma commonly. We don't have that data sometimes, especially in specific settings, regions. Using safe alternatives, reducing the sensitizing potential, education programs are very important, both the employee and the employer. Then occupational hygiene measures. Sometimes people are not bothered to use protective devices, especially, then monitoring and controlling the exposure levels. Sometimes we may not be able to completely get rid of the problem in an industrial environment. Then secondary, early detection. Again, institute medical surveillance programs, education of the healthcare workers. Now we have these resident medical officers in these various industries. Very important to educate them. Then the tertiary, how we treat the patient. Separate the patient from the trigger is the key. Evaluation of the symptomatic workers, controlling workers' relocation to a separate place, controlling other possible triggers. There can be cross-reactivity. Then pharmacological treatment comes at the bottom actually. Then monitoring of the patient's asthma control. It's very important to keep on monitoring. Then the overall management. Irritant-induced asthma, the key is to reduction of exposure. Then the sensitizer-induced asthma, cessation from the work-related exposure. Consider reduction exposure. Allergic immunotherapy and biologics in very selected cases only. Then pharmacotherapy, follow-up, education, and other general measures. Then prevention at occupational setting, elimination of the agent from the workplace, reduction of exposure. There can be various specific measures: good housekeeping, maintenance, waste disposal, exclusion of susceptible individual from high-risk workplace after employment examination. So there should be a communication between employee, employer, and the healthcare team. Periodic examination of workers in high-risk industries. So we have to identify what these high-risk industries are. Then what are the challenges we are facing? Lack of sensitivity and specific diagnostic tools and tests is a problem. Then lack of standardization and validation of most of the available extracts of occupational agents for immunological tests. So those are not available, not very standardized. Lack of epidemiological data. Then pathobiology is still poorly understood. Then variable presentation and treatment response, those depends on the individual patient. Then legal implications associated with occupational asthma, financial compensation, and the physical fitness for certain occupations, maybe military and other services. The lack of large cohorts. So isolated cases are reported. So there is no uniform data collection and kind of large cohorts. Then what are the future needs? We need databases on occupational asthmagenic agents, ideally. We don't have a kind of integrated system and uniform data collections, especially in our country. Then research on more sensitive and specific diagnostic tools. Research on molecular diagnostics, so we can endotypes and we can find out the direct link between certain agents and the patient's genomics, and we can offer more specific targeted treatment. Then increasing awareness in different categories, employee, employer, and the healthcare teams, and different levels of the healthcare team. Then more comprehensive guidelines. Still we don't have much specific guidelines on this occupational asthma. GINA guidelines actually suggest to refer occupational asthma patients to specialists. So in summary, it's a heterogeneous disease, one of the most prevalent occupational lung diseases with a significant socioeconomic impact. There are at least two phenotypes. Precise diagnosis is needed, and history of occupational exposure. The temporal relationship has to be established, and there is more accurate gold standard tests, which are not practical sometimes. Diagnosis of occupational asthma is difficult, and early removal of the worker from the exposure is the key. Then primary, secondary, and tertiary prevention. The pharmacology therapy comes next, which is similar to our normal asthma management. Then education and development of institutional medical surveillance program, which has to be specific for the industry, maybe. These are the references, and thank you.
Thank you, Gula, for a very important area. Actually, we talk less on this occupation asthma. That knowledge is mandatory as a practicing respiratory physician and all the doctors. Otherwise, we will try to manage it almost always with pharmacological treatment without giving the proper emphasis on this particularly important area. Now we'll move into the last lecture on this first session, facing the enigma of preschool wheezing. Dr. Anuradha Kodipilis is a consultant pediatric pulmonologist as well as senior lecturer at the University of Colombo. Anuradha.
Good morning, everyone. First of all, let me thank the Sri Lanka College of Pulmonologists for giving me this opportunity to talk to you on facing the enigma of preschool wheezing today. This is the outline of my lecture. So due to the time limitation, I will not be addressing the acute management of preschool wheezing and bronchiolitis, but however, I'm happy to answer if there are any questions at the end of the session. So what is preschool wheezing? So it's simply a preschooler who wheezes. So what the big fuss about that? So nearly 50% of children wheezes at some point during their life, and recurrent wheezing is defined as 4 or more episodes of wheezing per year. And preschool wheezing affects 1/3 of preschoolers with significant impact on quality of life, but all wheezers, we tend to manage all wheezers as asthma, but we should understand that all wheezers do not have asthma. So I would like to highlight this umbrella model. In most of the pediatric respiratory diseases actually comes under this umbrella model. The chronic cough, there are multiple etiologies. The bronchiectasis, there are multiple etiologies. Like that preschool wheezes, there are multiple etiologies. It is not just asthma. This is the most important that we need to highlight. So what is the enigma? There is yet no consensus on appropriate way to diagnose and manage preschool wheeze. And then why? That is due to the heterogeneous nature of the preschool wheezing, lack of clear definition of preschool asthma, and then paucity of scientific evidence concerning its underlying endotypes, not the phenotypes, and lack of objective tests, especially, and the difficulty in performing the test at this age group. So appropriate identification, classification of preschool wheezers for the purpose of initial assessment, therapeutic delivery and preventive care is still an unmet need. So what should be the objective of the clinicians? So if there is a dilemma, the primary objective of the clinician is to identify the serious and alternative underlying pathologies that might mimic asthma or preschool wheezing, and then to investigate and treat those specific etiologies if there are alternative etiologies, and then to identify viral-induced wheezing, and then finally to identify a child with symptoms suggestive of asthma syndrome, and then to commence on the asthma treatment. So I would like to first focus on identifying the alternative etiologies, which is very, very important. We as pulmonologists see many children who have been managed as wheezing, because in those days actually it's very difficult to put a little child on inhalers because parents would resist. They do not like inhalers, but nowadays actually they do like, they are more knowledgeable, and then most of the doctors at a drop of a hat start inhalers. And then they escalate treatment. They are more aware about the GINA guidelines and all, but sometimes they do not evaluate the child for alternative etiologies when they come with recurrent episodes. So these are some of the alternative etiologies with the red flags that I have mentioned. So obviously if there are recurrent viral respiratory infections associated with wheezing, that is actually viral induced. And gastroesophageal reflux can manifest as cough with feeding, vomit, especially after large feeds. And if it is a small baby, say less than 1 year, choking and cough with feeding might reflect H-type fistula and structural anomalies as well. And then tracheomalacia with or without tracheobronchomalacia, again a very interesting structural malformation that can present as preschool wheezing. But they usually their symptoms present since birth, and their cough is harsh with laryngeal involvement, and they do have prominent chest retractions rather than subtle intercostal recessions. So they look horrible, but they have tracheomalacia than wheezing. And then they predominantly have noisy breathing. Congenital heart disease, obviously, it's easy if you pick up a cardiac murmur. And then foreign body aspiration, they can present as recurrent wheezing, but if you dig into the history, they might give an event where the child developed an abrupt severe cough, most probably while eating peanuts or something, and then they go on having wheezing, and then we might be managing that child as asthma. Tuberculosis, positive contact history, poor weight gain, so it's very important for us to have a look at the growth chart in children with preschool wheezing, because that reflects a lot. So most of these diagnoses that I've mentioned in this slide, actually they have growth failure. Cystic fibrosis, they present as recurrent chest infections and wheezing, but they do have failure to thrive plus or minus steatorrhea. I have diagnosed 4 children with cystic fibrosis during my training who have been managed, some at tertiary centers as asthma, with typical clinical profile of cystic fibrosis. So it is very important that we understand that cystic fibrosis do exist in Sri Lanka. And primary ciliary dyskinesia, respiratory distress in term babies, they do have symptoms from the beginning. They are tachypneic from birth usually. They have chronic ear infections, sinopulmonary infections, because it's prime ciliary defect. So it's important to ask a couple of questions to see whether it is suggestive of PCD. However, we do not have actually diagnostic tests for PCD in Sri Lanka. Vascular rings, they present with wheezing. They have stridor or high-pitched cough or repeated pneumonia. Bronchopulmonary dysplasia with the history of prematurity, you do have to suspect BPD in children who present with wheezing. And immune deficiency if they have any other systemic infections other than the respiratory. So if above red flags are elicited, we do have to refer the patient to a pediatrician or pediatric pulmonologist for assessment. So the next question is, so once we have ruled out those alternative etiologies, the next question is it preschool asthma? So a preschooler who is wheezing, so what makes them more probable to have asthma? So these 3 features are actually given in the GINA guideline, the latest GINA 2023 guideline, and that was pretty kind of existent for a long time. So if a child if the child has wheezing or coughing, which is getting worse with exercise, laughing, crying, and the absence of upper respiratory tract infection, that suggests asthma. And then if there's a personal or family, first degree family members having other atopic diseases or wheezing, like allergic rhinitis, allergic conjunctivitis, food allergies, so then that suggest asthma than an alternative etiology. And if there are, more importantly, if there's a clinical improvement of symptoms with controller medications used for 2 to 3 months, or if there is reappearance of symptoms once you cease the treatment, that also suggests preschool asthma. This is actually the probability-based classification of asthma, again given in the GINA guideline. So you can see, so this can be a few have asthma, some have asthma, more have asthma, and it was given in low probability, intermediate probability, and high probability as well. So you can see if the symptoms of cough, wheeze is present more than 10 days during upper respiratory tract infections, if there are 3 episodes per year, and then between the episodes, if the child has cough, wheeze, or heavy breathing, or if they have personal or family history of atopy in the third column, that makes a child more susceptible or more having more probability of preschool asthma. If we go by this kind of classification, can we really diagnose preschool asthma clinically? So can we diagnose asthma in less than 5-year-old children? So this is a systematic review, asthma diagnosis in infants and preschool children, a systematic review of clinical guidelines. So they have reviewed about 1,000 studies and the guidelines, and they have finally focused on 23 latest guidelines on the management of preschool wheezing. And then they concluded the immense majority accepted that the asthma can be diagnosed from the first year of life without requiring pulmonary function test or other complementary techniques or lung function. So if you rule out, as I mentioned in my first couple of slides, if you rule out sinister or other pathologies, and if you go by the clinical guidelines, you will be able to, narrow down the preschoolers with asthma to a greater extent. So that is what this study says. The response to treatment and the exclusion of other alternative diagnosis is a key element to establish the diagnosis. Only one guideline denied the possibility of diagnosing asthma in preschool children clinically. So, however, this symptom time-based approach is currently challenged. Why? So the conventional history-based models are, so we used to classify preschool wheezing or asthma as symptom-based, like episodic viral wheeze or multiple trigger wheeze, and time trend-based classification, transient wheeze, persistent wheeze, intermittent or late onset wheezing. So, but hope you would appreciate that these classifications depends on maternal reporting of symptoms or the documentation at different places. And then airways respond to diverse external stimuli with a limited range of symptoms and signs. That's the beauty of pulmonology. With different etiologies, actually, you might only get cough, wheeze, shortness of breath. So going by these symptoms is not very reliable in arriving at a proper diagnosis, especially when it comes to targeted therapy. So many pathophysiologies with different individualized treatments are expressed with wheezing and cough, which are similar symptoms. So hence, managing the wheezing child based on the airway phenotype approach is currently suggested. So this actually was taken from this study which was published by Anne, and she also gives this the umbrella. I have already introduced this umbrella kind of model of the preschool wheezing, and she also highlights the same thing. So wheezing asthma is a syndrome, which is again it's an umbrella, and then under that there are different phenotypes that we described earlier, and then there are different endotypes or airway phenotypes that we should try to understand if we want to focus on personalized therapy. This study, led by Andrew Bush, a famous pulmonologist in the UK, also highlight that airway phenotype-based approach is very important if we want to give a targeted therapy. So that approach enables the clinician to identify the children with serious underlying pathologies, increase the specificity of treatment for the children, and then identifying the treatable cause. So objective test to phenotype the airway and then to identify treatable risks. What objective test have we got? So first of all, we should verify the presence of reversible airway obstruction, and then we should look at whether there is eosinophilic inflammation, whether there is neutrophilic inflammation, or whether there is no inflammation at all. So objective test to pulmonary phenotype the airway, verifying the presence of reversible airway obstruction. I think Ruwanti gave a nice account on this, so I do not want to actually repeat that. So, but what I want to highlight is these tests are really difficult in children less than 5 years of age. Even spirometry is difficult because that is a test which needs sort of cooperation. But theoretically, it is shown that children between 3 to 5 years have shown performed spirometry effectively. And then impulse oscillometry is a tidal volume based test where you can diagnose airway obstruction, airway resistance with tidal breath without the child having to exert an effort. So these tests are used to establish the reversible airway obstruction in children, even though we do not use it clinically much due to the availability plus the difficulties in performing. So why do we need an airway phenotype based approach if we can diagnose it clinically? Why do we need an airway phenotype based approach? I have mentioned that it is for individualized management to decide on the effectiveness of inhaled corticosteroids. Do you know that inhaled corticosteroids works best when there is eosinophilic airway inflammation? So if we can identify the eosinophilic airway inflammation, that is very, very helpful for us to manage preschool children effectively. So this study, again led by Andrew Bush, done by Robinson, I have extracted a couple of graphs from this study, which is very interesting. Recurrent severe preschool wheeze from pre-specified diagnostic labels to underlying endotypes. So this is, so basically their objective was to investigate lower airway inflammation and infection in preschool children with different clinical diagnoses undergoing elective bronchoscopy and BAL. So they have undergone elective bronchoscopy and BAL. They were enrolled to perform elective endoscopy. So 136 children aged 1 to 5 years were recruited, 105 with recurrent severe wheezing, and then 31 with no wheeze, not wheezing respiratory disease. And then they tried to determine the clusters of pathophysiological features. So let's look at this graph, which is very important. So they have found that there is no relationship between lower airway inflammation and clinical wheezing phenotype. So you can see multiple trigger wheeze and then episodic viral wheeze, and you can't see any difference in eosinophil or neutrophil, blood eosinophilia or neutrophilia, or BAL eosinophilia or neutrophilia. So that would not, so this clinical phenotype would not reflect you whether they are eosinophilic or neutrophilic inflammation. So let's see the next one. So this is interesting. Correlation of BAL eosinophilia to atopic wheezes. Then they went and looked at the atopic wheezes. So they diagnosed atopic wheezes with the skin prick test and specific IgE. And then they looked at whether there's a difference of BAL eosinophilia in atopic and non-atopic individuals. And they have found that in atopic individuals, BAL eosinophilia percentage is really high. So if we can pick up atopic individuals, then we would know that they probably have the high chance of having eosinophilic inflammation, and they would be a group who would be responding to inhaled corticosteroids. So that is the conclusion that we can get from this. And then interestingly, so can we do BAL every time? No, we can't actually. So we can't. So is there a surrogate marker? Yes. So positive relationship between blood and BAL eosinophilia is in preschool wheezes. Again, the Robinson study. They say assessing peripheral blood eosinophilia is helpful to identify preschoolers who might respond well to ICS, because BAL eosinophilia is well correlated with blood eosinophilia. So now we know if we do blood eosinophilia and then blood eosinophil count, and if we do a skin prick test or specific IgE in difficult asthma, Shanna will be discussing on difficult asthma in preschoolers who are difficult to manage, we might be able to identify the group of children who probably will respond to ICS or will not respond to inhaled corticosteroids. So this is again another study, the individualized therapy for asthma in toddlers infant study. This is a multi-center randomized double-blind clinical trial in children aged 12 to 59 months with asthma necessitating treatment with daily controller. And then participants have completed actually three crossover periods with daily inhaled corticosteroids, daily leukotriene receptor antagonist as needed ICS treatment. And then their primary outcome actually was to see the differential response to asthma medications based on composite measures of asthma control. So this actually adds to the Robinson study. So if you can see this, I'm sorry, it's not very clear. So basically this red line shows the response to inhaled corticosteroids. So assessment, so they have done this assessment at the clinic visit when they are very well. They have tried to identify the differential responders to inhaled corticosteroids. So the best responders are the children who are atopic to aeroallergens and who have high blood eosinophilic count. So in this graph, so so in the small fonts you can see they are sensitive to aeroallergens and their blood eosinophil count is more than 300, and then in red you can see the response to inhaled corticosteroids. So this axis is the cumulative exacerbation probability. So you can see that the exacerbation probability is low in this graph. So that is interesting. And then this is another one, again Robinson study. So BAL clusters of children with severe wheezing and asthma. So this is a cluster analysis of children who were bad enough to require a BAL bronchoalveolar lavage, showed two main preschool clusters. One cluster, which is red here, is severe recurrent wheeze with sensitization to aeroallergens, and this blue cluster is neutrophilic steroid refractory recurrent wheezes. So you know that in that case there is a cluster with neutrophilic steroid refractory group of children. And again here they show neutrophils are higher in children with positive culture. So they have done BAL cultures. So in children with positive BAL cultures, their BAL neutrophil concentration percentage is also high compared to children with negative cultures. So that shows us that infection-driven neutrophilia could be the probable reason here. And then there is a place of treatment with antibiotics. So the preferred antibiotic is macrolide, which has antibiotic and antibacterial properties. So it's very important for us to understand that there are at least two key phenotypes with eosinophilic inflammation and neutrophilic inflammation. Children with eosinophilic inflammation will respond to inhaled corticosteroids well, but children with neutrophilic inflammation might not respond to inhaled corticosteroids. So there's no point of escalating according to this ladder, GINA ladder, but it's very important if we can evaluate the child a bit more to see whether this is a child who would require a course of antibiotics. So I don't want to I'm not going to repeat the GINA guideline, but this is what I want to highlight here in the management of preschool asthma given in the latest GINA guideline is couple of things. So they do not recommend LABA until the step 4, and then these are actually basics that every preschooler should be reviewed for symptoms, and then the response, the inhaler technique. Inhaler technique actually you do have to remind like at every visit because they tend to forget, and then before you escalate you have to review, reassess, and then adjust the doses. And then so this is a standard treatment ladder. Where at step 4 you need to assess the child and then refer to a specialist for assessment. And then this is the airway phenotype based management, which I have taken from that Andrews study. So they suggest so history and physical examination verifying the presence of wheezing. If there are atypical patterns of wheeze, presence of red flags, the one that I have mentioned in those two graphs, you do have to investigate them for specific etiologies with investigations. If there are no red flags, but the preschool child has recurrent wheeze and asthma-like symptoms, they do advise to do, even though it is not feasible for us in our setup, to do aeroallergen sensitivity and eosinophilic count, and then to go for inhaled corticosteroids, and then if they are negative, to try a trial of antibiotics. So summary, preschool wheezes are highly heterogeneous with still poorly understood endotypes. There is no correlation between symptom pattern and the underlying pathology. Moving beyond history taking as a guide to therapy is very important. Much more objective personalized treatment strategies are required, and cystic fibrosis is one wonderful example where you do personalized treatment based on the endotypes and genes, and then where you have achieved good success. So we need to develop new biomarkers, airway phenotypes, but more importantly, move to understand the underlying endotypes. Thank you. So,
thanks, Anuradha. Very important area of preschool visa.